Hi, and welcome to the Geriatric Lecture Series. My name is Ryan Carnahan. I'm a psychiatric pharmacist and epidemiologist at the University of Iowa. I'm going to be talking with you today about delirium. So before we dive in, I do want to provide some acknowledgments in my disclosures. I don't have any financial interests or relationships with any manufacturers of products. I am employed by the University of Iowa, which provides healthcare services. I'm supported by PCORI, HRSA, and AHRQ for work related to this presentation, but this presentation is my own opinion and does not reflect any of their opinions. And no drug has an FDA indication to manage delirium, so any kind of drug treatment that I'm talking about today is really off-label use. So the objectives for today, the things that I'm hoping you can do at the end of this lecture, are to recognize the signs and symptoms of delirium, identify risk factors and potential causes of delirium, including high-risk medications, list screening tools useful for identifying delirium in practice, and describe interventions to reduce the risk of delirium in high-risk patients. And finally, I'm hoping that you'll be able to implement some of these interventions to manage symptoms of delirium. So I want to start off with a case study just to get you in the right mindset and thinking about what delirium might look like. It can present in many different ways, but this is one. So Blanche is an 82-year-old widowed female living at home. She has mild memory loss, but still manages most of her activities of daily living and instrumental activities of daily living with some minimal assistance from her daughter. But they found her early this morning wandering barefoot in her neighborhood in her night clothes before sunrise. So I'd like you just to take a moment and think about what questions that you might ask to try to figure out what's going on with Blanche. So we'll come back to Blanche later on. So I do want to talk about the diagnostic criteria for delirium, and I'll talk a little bit more about some of the ways in which it might present as well. So delirium is a disturbance in attention and awareness. The attention disturbances are recognized by a reduced ability to direct, focus, or sustain or shift attention, and awareness would be reduced orientation to one's environment. The disturbance develops over a short period of time and represents a change from baseline attention and awareness, and tends to fluctuate in severity during the course of a day. So this is really a major distinction from a person who might have dementia or another illness that is causing some sort of cognitive impairment, is that this is a rapid change from baseline. Many people will have impairments in different aspects of their cognition, and actually delirium is very common in people with dementia. Delirium superimposed on dementia represents a large proportion of cases. But if you see a dramatic change in somebody's functional level or their level of attention and awareness from what they have been recently, then this is much different than what we typically see as a more slow and steady type of cognitive decline in dementia. There may be additional disturbances in cognition, including memory deficits, disorientation, problems with language, visuospatial ability, or perception. And the disturbances, the cognitive problems, are not better explained by another pre-existing, established, or evolving neurocognitive disorder, such as dementia, and do not occur in the context of a severely reduced level of arousal, such as a coma. So somebody who's over-sedated can definitely be experiencing delirium, but if somebody just isn't awake, then we really can't evaluate how their cognition is doing. And there's evidence from the history, physical examination, or laboratory findings that the disturbance is a direct physiological consequence of another medical condition, substance intoxication or withdrawal, or exposure to another toxin, or is due to multiple etiologies. And so this is something that's caused by a medical problem, be it a toxic exposure or the medical problem that's not well controlled. And I would say more cases than not, it probably does relate to multiple etiologies. There's certainly single cause cases such as an overdose of a medication, but in many cases a person has a number of different medical conditions or predisposing factors. And then on top of that, they may have some precipitating factors that cause them to basically push over the edge into delirium. Delirium is very common. If you're taking care of older patients, you've probably seen it. It's been estimated that about 10% of hospitalized patients over 65 are delirious on admission, and an additional 10 to 15% may experience it while in the hospital. Here at the UIHC, we've seen rates of positive screens for delirium of 20% or a bit higher, where people are, at least per the screening tool we've implemented, at least during their stay having a positive screen indicating at least some symptoms of delirium, even if not full-blown delirium. So that happening in really just over 20% of patients. So it really is a very common syndrome that you'll see in the hospital because those people are having serious medical problems that may push them over the edge into delirium, as well as due to changes in the environment and other factors. 22 to 89% of hospitalized elderly with dementia, so that's a very wide range, but those are the estimates are estimated to experience delirium. So dementia is a huge risk factor. It's basically one of the major predisposing factors that if they may have even minor medical issues or exposures to medications that push them over the edge into experiencing delirium. And about 2/3 of cases have been estimated to have a baseline cognitive disorder. So they really do represent a large proportion of those cases. There was a study done by an investigator here at the University of Iowa, Ken Kolp, which I was lucky to be involved in peripherally, where he found that about 20% of elderly nursing home residents experienced delirium during a 1-month period. Not all of those were very severe or long-lasting, but they did meet the criteria for delirium. Delirium is associated with a lot of adverse outcomes, which is one of the reasons that we're very concerned about it. Of course, it can be very distressing to the patient and to their loved ones, and for their caregivers, any kind of caregiver as well, whether it's professional or unpaid. So that somebody may be experiencing a lot of distressing symptoms, people aren't sure what's going on, they're not sure really how to interpret it, and so helping them understand what's going on, I think, is something important that we'll talk about a little bit more later. It's associated with increased morbidity and mortality, and whether delirium is causing that or whether it's just happening in those patients with more severe conditions is fairly difficult to discern and to evaluate clearly in research, but we do know that those people who experience delirium have worse outcomes. The mortality is quite high in these patients. Delirium is associated with future functional and cognitive decline. We don't necessarily know, again, whether the delirium is causing this, and then it might actually be a neurotoxic insult, or whether it is a marker for somebody who is at risk for further functional and cognitive decline. And that probably depends on the cause of delirium. If somebody has an anoxic brain injury that's causing them to be delirious, then of course that's going to be associated with future problems. But if it's an acute overdose that doesn't actually lead to any brain damage or anything like that, then whether or not somebody's going to resolve up to their regular baseline, that may be different in that type of a case. But we do know that those people who experience it are at risk of further problems. It increases length of hospitalization because people it requires this additional care, and we don't necessarily want to send people out from the hospital when they're still confused. And people may be more likely to go to the nursing home, require other types of additional care at home if their delirium has not resolved or if they're still at risk. So some of the core symptoms that we talked about in the diagnostic criteria include disorientation, so somebody might not know where they are or when it is. Confusion, so they're just not interpreting their environment well. They're not understanding people well. They may not be able to communicate well. Memory dysfunction, so they're not necessarily remembering things that are going on. An altered level of consciousness, in which somebody is typically looks somewhat sedated or agitated and hyperactive. Impaired attention, and a fluctuating course. And these last ones with the asterisks are fairly key in differentiating delirium from dementia. As I said, we expect much more of a fluctuating course in delirium, where people may have moments of clarity and then be quite confused at different times throughout the day. And we don't necessarily expect a lot of impaired attention, at least earlier in dementia. As somebody gets more severe, this becomes more difficult to evaluate. And we also don't necessarily expect them to look overly sedated or to look hypervigilant and agitated, as may occur in some cases of delirium. Other symptoms we might see include anxiety, agitation, hallucinations, apathy and withdrawal, which is more of a symptom of hypoactive delirium, which is not recognized as much. Sleep disturbances and cycle reversal, so people may be up at night and sleeping during the day. Their circadian rhythms are definitely off in delirium. They may have emotional lability, reacting to things excessively, at least beyond what you would expect. Perceptual disturbances, where they're seeing things, not necessarily hallucinations that aren't there, but misinterpreting their environment and thinking things are something other than what they are, as well as potentially other neurologic signs. Delirium is often described as in subtypes, hyperactive delirium, hypoactive delirium, or mixed, in which people fluctuate between the two. I have seen work on delirium in basically regular levels of consciousness, where they're not necessarily obviously hyperactive or hypoactive, but they are definitely acutely confused, which is really a synonym for delirium, acute confusion. So in hyperactive delirium, these are the cases that people recognize pretty readily. People are agitated, disoriented, and psychotic. They may be trying to climb out of bed when they shouldn't be, which puts them at risk of falls. They may be pulling on IV lines or catheters and having other agitated behaviors. And so these are the cases that people know about because they're causing problems. The hypoactive cases we know are under-recognized, and people can't just say, well, I'll know if somebody's delirious, because somebody just may be quiet and keeping to themselves, and without some further evaluation, it's not really as clear whether they're experiencing delirium or not. This is often confused with depression or dementia, and so that's the consult psychiatrists I talk with say, I get these consults for depression, it's almost always delirium. And so people are just there, they're quiet, and they're not really doing anything that's drawing attention to them. But hypoactive delirium has really been associated with very negative outcomes, increased mortality, perhaps even beyond in hyperactive delirium. So it is an important condition to recognize. And then mixed is, again, where they just fluctuate between these two types of states. So now if you take a moment, again, I can't really talk with you, but I do want you to take a moment to reflect and think about what types of patients you most commonly see delirium in. So it's likely that if you're watching this that you've seen enough patients that you've seen a case of delirium, and to think about what were those patients like, how are they different from other patients that seem to not experience this. Of course, any patient can really experience delirium, but there are definitely risk factors for it. And so serious illnesses, really any kind of serious illness is a risk factor for delirium. Certainly certain types of illnesses, when they're out of control, are going to cause it more often than others, but it's really not limited to any specific type of medical problem. Or cases of drug intoxication or withdrawal. And intoxication can really be at a very high level, where somebody is overdosed on a very large amount of medication, or simply that they're getting too much medication for their ability to tolerate it. And so even lower levels, especially if somebody has a lot of predisposing factors like dementia, even normal doses of medications may cause delirium. We don't really have a great understanding of the pathophysiology. There's been a lot of research into this. There's some theory that a deficit of acetylcholine is a final common pathway for delirium. There has been work on inflammatory cytokines or cortisol, and thinking that these may be interacting with the central nervous system to cause these cognitive problems in acute illness. But I think it's a difficult thing to study, and we don't really understand it fully. The types of patients, the risk factors that you might consider would be things like hospitalized older patients, people with a lot of medical conditions or a lot of medications. Terminally ill patients are at risk. Children are actually at high risk. And people with sensory deprivation, so anyone with a hearing or visual problem, if we can correct that by use of hearing aids, by clearing out earwax, by making sure that people have their glasses, that can help them remain oriented and more aware of their environment and potentially reduce their risk of experiencing delirium. And then sleep deprivation. So if sleep disturbances for whatever reason may contribute to delirium because people are off in their circadian rhythms, they're not well rested, they don't have the capacity to handle insults and maintain their homeostasis that they would otherwise have. And sleep problems, as I said, circadian rhythm disturbances may also be a symptom of delirium. So it's a problem, but if you've ever pulled an all-nighter or whatever, stayed up for a really long time, then you probably know that you weren't thinking as clearly as you were if you would have gotten a good night's sleep. So this isn't too hard to understand. Some of the medical conditions that we might particularly think about as being high risk are, of course, I've mentioned dementia. People with dementia are quite susceptible to experiencing delirium. People that are following a major surgery, cardiac surgery, hip replacement or knee replacement, and transplant patients are at high risk. And so if you think about anything where there might be some blood loss, some anoxia, and those types of things, those are definitely likely to cause some risk, as well as anesthesia itself. Some people have difficulty coming out of anesthesia, and they experience delirium at least until that clears. People with burns are at high risk. Any sort of abrupt discontinuation of alcohol or certain drugs may trigger delirium. People that aren't well nourished, with liver disease, on dialysis, with kidney problems, and some of the liver and kidney problems can also impact their ability to metabolize and clear medications. So we've definitely seen some cases of delirium reported where somebody got a medication you wouldn't have really thought about as being a major risk factor for delirium, but they had renal impairment and it wasn't adjusted for, the dose wasn't adjusted for that, and they ended up experiencing confusion as a result. People with Parkinson's disease, either by way of having some Parkinson's dementia, or because of the medications that are used to treat the movement disorders in Parkinson's disease, may be at higher risk. People with HIV or AIDS and people after a stroke are maybe at particularly high risk of experiencing delirium. There are a number of mnemonics that are used to try to remember the different potential causes of delirium. I somewhat jokingly put Harrison's internal medicine textbook up here because, as I said, just about any medical condition can cause delirium in a person who's at risk. But these can help us remember some of the more common ones. And just remembering that they exist, if you don't necessarily memorize these today, you can find them online. I have here the ICUdelirium.org website from Vanderbilt, who have done a lot of work, particularly in ICU delirium, where these mnemonics can be found. And so this one is deliriums, and it starts off with drugs, 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 not drugs just once, but 3 times, because drugs are a major risk factor and a common cause of delirium. Eyes and ears, so again, thinking about with somebody, do they have their glasses, do they have their hearing aid, is their earwax cleared out? So that is important. Low O2 states or anoxia that I've already mentioned. Infections, retention of urine or stool can lead to delirium. Seizures, represented by ictal. underhydration or undernutrition, metabolic problems, or subdural hematomas, or sleep deprivation. So when thinking about infection, I know one of the big ones we think about often is urinary tract infections. And this one becomes a little bit difficult because oftentimes when somebody with dementia, for example, experiences some changes in behavior or in cognitive status, this is one of the first things we think about. A urinary tract infection could be causing it, and sometimes it does. The challenge becomes in determining whether somebody actually has a UTI or whether they may be colonized by bacteria. Because if you start looking at nursing home residents, especially those with dementia, we find very high rates of asymptomatic bacteriuria, where people are, they have bacteria in their urine, they're colonized from it, perhaps from a catheter, perhaps from other reasons, but they're not actually acutely experiencing an acute infection with symptoms that are local and with fevers and other things like that. It's just that these bacteria have colonized their urinary tract. So it can be difficult to decide whether it is the right thing to do is use an antibiotic that may cause C. difficile or other problems, or whether to hydrate somebody and watch and wait for a culture to come back to think about if you do use an antibiotic, which one to select. And so if there aren't localized symptoms in that particular case that I'm just highlighting because I think it's a common scenario, then I think it is worth stopping and considering whether giving an antibiotic right away is the right thing to do, or whether to continue the investigations into other potential causes. But I'll move on. Another mnemonic is I watch death, and this covers some of the same ideas: infection, withdrawal, acute metabolic problems, trauma, CNS pathology, hypoxia, any kind of deficiency, endocrinopathies, acute vascular problems, toxins or drugs, and heavy metals. So again, these are there on the Vanderbilt site if you want to go back and review them. Being a psychiatric pharmacist, I tend to think a little bit more about what is unique about patients with psychiatric conditions and what unique risk factors do they have. They're exposed to psychiatric medications, which is somewhat of a risk factor in and of itself, with some medications more than others. And so we think about the side effects of those meds as well as other potential issues that may be more common in this population. So starting out, we might think about neuroleptic malignant syndrome in patients who are on antipsychotics. So if they experience rigidity, a high fever, and confusion, then we got to be worried about this because it is a potentially deadly condition. And then serotonin syndrome often presents somewhat similarly, although people tend to have more GI symptoms. They are similarly overheated, and they may have some spasticity. And so serotonin syndrome can occur in patients on SSRIs, or if they get that combined with tramadol or certain other medications that can increase the risk of serotonin syndrome. And so we have to be careful about that as well. In patients with a history of alcoholism or active alcoholism, we worry about thiamine deficiency and Wernicke's encephalopathy. And this can also happen outside of the context of alcoholism. If somebody's had a lot of vomiting or anything that may cause a thiamine deficiency, then they're at risk. And so the little tidbit I'd like to suggest here is to think about any patient who you're going to give glucose replacement to as a potential risk for Wernicke's encephalopathy. So if we use what we call a banana bag, or if we do, which was glucose with thiamine in it, or if we can replace thiamine before giving glucose, I really think this should be a universal practice just to avoid having any cases of Wernicke's encephalopathy. I can't think of really any problems you're going to cause by adding thiamine to that bag. And if we can prevent one case of Wernicke's encephalopathy, then I think that it's been worth it. Because this really can be chronic, irreversible brain damage that happens. Cases of drug withdrawal, I've mentioned. Alcohol withdrawal is quite a common cause, and we don't always have a great history on somebody who's been drinking. So somebody who comes into the hospital, we always have to be concerned about this because they're probably not getting drinks in the hospital. or any type of sedative hypnotic. Benzodiazepines would be the ones that you would see most commonly. So if somebody's taking that chronically, we can't just stop it abruptly, because they may experience withdrawal symptoms, and which can lead to delirium tremens, which again can be potentially deadly. Most psychiatric medications, if somebody overdoses, they are at risk of experiencing delirium. Certainly some at more therapeutic types of doses. If they just get a little bit too high, we can see problems. Certainly problems with delirium, with lithium. And so older people tend to be able to tolerate lithium at lower levels as well compared to younger patients, in part because it seems to get into the brain more readily at the same blood levels. So we may want to be targeting lower lithium blood levels in older patients to prevent this problem. But I've seen confusion in younger people as well. Any kind of anticonvulsant given at too high a dose or titrated up too quickly may cause some cognitive problems. Anticholinergic drugs are some that are highlighted on the Beers list of potentially inappropriate medications in the elderly, and that I've studied quite a bit. And despite the warnings about these medications, they're really used quite commonly. So I'll talk a little bit more about those in a few moments. And tricyclic antidepressants are anticholinergic and can, again, cause these types of issues, and any sort of sedating medication. Antipsychotics are not one that we typically think about because they're actually used as a treatment to manage symptoms of delirium. But I've talked with others about this and have the feeling that if people are getting too high of doses of antipsychotics, they may be also at risk of delirium. I've definitely seen cases where there appear to be some cognitive deficits related to an antipsychotic dose. Antidepressants, we often think of those as pretty safe medications, the SSRIs and other newer antidepressants in older adults, but they really can cause some problems, such as syndrome of inappropriate antidiuretic hormone secretion, which can cause hyponatremia. So if you see GI symptoms and confusion and some other things, then electrolyte disturbances are definitely something that we would want to evaluate if somebody is experiencing delirium, and antidepressants may be one contributor if they have low sodium. And then valproate or valproic acid, also known as Depakote, can cause hyperammonemia. And so if I see a patient on that, then I would definitely think about increased ammonia as one of the potential causes. There are lots of ways to screen for delirium. A number of tools have been developed, and I'll talk about some of those that I think might be useful to you. And I also just want to highlight that I think it is important that we do screen for delirium. Here at UIHC, we were able to work with nursing and others to implement delirium screening for all patients that are age 65 plus. And as I said, we really see it in quite a few patients. And we know from research that delirium isn't recognized as much as people probably think they're recognizing it if you don't do any sort of systematic screening for it. As I mentioned, especially those hypoactive cases are not necessarily likely to be identified without more thorough evaluation. And so to identify it, you can really use probably just about any sort of cognitive measure tool that you have, if you have sort of a baseline score and you know what somebody's baseline is. So if they've got dementia, you can't necessarily just give an MMSE and know that they have delirium unless you have a fairly recent score. But if you know that those scores are fluctuating over time, then that definitely is suggestive of some potential delirium. Although the MMSE is probably a fairly labor-intensive type of strategy to use for screening for delirium, so there are other more delirium-specific types of tools that we can use. The confusion assessment method is a well-validated and well-established tool that's been used quite a bit in research. There is also a version for the intensive care unit that was developed by the group at Vanderbilt. It is based on DSM-4 criteria, which are basically consistent with DSM-5, the ones that I showed you at the beginning of this. And it requires that somebody, these are the core items, there are some other things that can be evaluated in the CAM, as it's oftentimes referred to. The core items are that somebody has an acute onset and fluctuating course of their cognitive impairment. And so that really takes a history and knowing the patient to understand that well. That there's some inattention, and there are different attention screening tools that can be used. A lot of patients, maybe you can have them count backwards from 20 or do serial sevens, counting backwards by 7 from 100, and that can be one way to evaluate attention. There's also something used in the CAM ICU that's called the Vigilance A test. And you use a fairly short version, but you ask people to squeeze the examiner's hand or otherwise indicate that they've heard an A when they read through this list of letters, a good number of which are A's. And you look for errors of commission where they squeeze when it's not an A, or errors of omission where they don't squeeze when it is an A. So these two core symptoms are required for a positive screen, and then a person has to either have disorganized thinking or an altered level of consciousness. And the disorganized thinking is evaluated by asking questions like, at least in the ICU version, they use things like, will a stone float on water? Are there fish in the sea? And so fairly straightforward questions that someone who's thinking clearly will be able to answer. And if they don't do well on those, then that's evidence of disorganized thinking. The altered level of consciousness can be evaluated by any sort of scale that's used to look at whether somebody's sedated or hyperactive and hypervigilant. So anything but a normal level of consciousness triggers that criterion. So we chose not to use the CAM when working with the group here at University of Iowa because it takes a little bit of time and a little bit of expertise to administer correctly. And the time burden that it seems to require to do as a regular screen that we're doing twice a day on everybody seems to be a little bit much. There is a nursing home version of this, and so if you're doing something ad hoc and saying, well, this person seems a little bit confused, I'm going to evaluate them for delirium, I think this is a great tool. And the minimum data set, which is used for nursing home evaluation, includes this or a slightly modified version as it's a recommended screening tool. And so we know it works well, but we also know it's a little bit of a burden on the people that have to administer it if you're doing it all the time. So we looked at some other scales and considered their use, and so I'll talk about some of the other commonly cited screening tools. The Delirium Observation Screening Scale is the one that we selected for use here. It has 13 pretty straightforward questions that nurses can answer just by observing the patient throughout their shift. It was felt to be pretty easy to use, and so we ended up implementing that here. The new desk, or the Nursing Delirium Screening Scale, has 5 questions, and there are some easy-to-use score sheets that are available. I've seen different estimates of its validity. In some cases, there was some work in postoperative patients by Karen Neufeld at Johns Hopkins that suggested it might not be that sensitive. And I saw some other validation work that suggested it might not be that specific. So it's 5 questions. It's pretty quick and seemingly easy to use. And so you have to think about what is the right threshold for triggering a further evaluation in somebody, and it seems to depend on the user as to whether it's working well. The single question in delirium, or the SQUID, is I think some folks think this was evaluated almost as kind of a joke to say, look, we can do just by asking somebody who knows this person just as much as we could do with one of these other fancier screening tools. And they found that if they just ask a family member or somebody who knows the patient well, if they seem more confused today than usual, that actually has pretty good performance in identifying and classifying delirium. And so that really is very much a key in thinking about whether somebody is experiencing delirium is whether they're more confused today than they usually are, and having an informant who knows that person well, who can help us understand that. That does speak somewhat to the importance of consistent staffing in nursing facilities. So if you can have a person taking care of a patient or a resident who understands that person well and can identify when something is off with them, then I think that's going to help you provide better quality care for that resident. So I'll just go through the delirium observation screening scale quickly. It's a 1-0 scoring for each question, whether it's present or absent, and scores greater than or equal to 3 suggest delirium. Those with the asterisk here are reverse scored, so they're good things instead of bad things. And so they ask the questions like, does the patient doze during conversation or activities? Are they easily distracted? Do they maintain attention? Do they not finish a question or answer? Do they give answers that don't fit the question? Do they react slowly to instructions? Do they think they're somewhere else? Do they know what part of the day it is? Do they remember recent events? Both of those are good things. Are they picking disorderly or restless, which is bad? Are they pulling their IV tubes, feeding tubes, catheters, or other lines? Do they have emotional lability? And do they see people or things as something or somebody that they are not? So this would be looking to that. Are they experiencing illusions, where they're seeing something as something else, or potentially hallucinations as well? So going back to the SQUID, that single question delirium, another resource that we have that you can download from our website is a guide for families that the group here developed from a version that was received from San Diego Hospice. So this was somewhat revised, and it went through the health literacy team here at the University of Iowa, hospitals and clinics, and we ended up with this brief handout that talks about delirium and how what families may observe when a patient is experiencing it. And we think that this could really be useful if people were given this when they come into the hospital, if the family members or others that may be there with them were given this resource, they could help us identify when something's going on. And delirium, I haven't really mentioned it, it's considered a medical emergency because it's a sign that something very bad is going on for somebody and that we really need to investigate and figure out what it is that's causing them to be so confused. So the earlier we can pick it up, the earlier we can intervene and try to resolve whatever the underlying cause is, which is really the cornerstone of treatment of delirium, is to try to get at what is causing it in the first place. So this brief handout is available. You can go to our website at the address there and download it. So one thing I want to mention is that if somebody has a change in mental status, I think it's important that we first suspect delirium as the potential cause. We don't just want to assume because somebody is showing signs of cognitive impairment that they have dementia. So the evaluation of dementia is another talk, but I think that it's just one potential cause of cognitive impairment that could be seen. And so that we want to do a good history and diagnostic evaluation, rule out other causes of cognitive impairment. And so as a pharmacist, I'm naturally thinking about medications and what medications could be contributing to this person's memory dysfunction or whatever else is going on with them, as well as uncontrolled medical disorders or other toxins. We want to eliminate those other potential causes and then reevaluate them and see, has that improved their status, has it not? And regardless of whether they have dementia or not, or maybe even especially if they have dementia, we want to do what I like to call pharmacologic debridement. And that is to get rid of medications that are not necessary that may be causing problems for that person. And so there are a lot of different medications that can contribute to delirium. Some of these are going to be necessary for a person and some of them are not. Basically you can see here just about anything psychoactive, but also some maybe things that we wouldn't normally expect, like antibiotics, and you can see steroids there. You might actually expect to see some mental status changes with steroids at times. And I have there at the top of the list anticholinergics, because I think in many cases they are not necessary medications, but they're medications that people receive anyway. So just to show you one study on an anticholinergic, and I'm highlighting this because actually I was just recently at a conference and people are telling me that when they're consulting in nursing homes, they're seeing a lot of patients still getting diphenhydramine for delirium. And so this is over-the-counter sleep medication, which basically any of these sleep aids that you can get over the counter are going to have diphenhydramine or another anticholinergic type of antihistamine in them, and that people think that they're safe, that these are safe, non-addictive, effective. And I've talked to people. I talked to one woman who was taking these for 2 years. Every night she took Tylenol PM, and she said, "Well, I'm also having these problems with dry mouth and dry eyes and dry, and I'm like, well, it's probably because you've taken this, every day for the last 2 years." And so people don't really recognize the potential risk of diphenhydramine when used for sleep. This particular study looked at older medical inpatients. About a quarter of them received diphenhydramine, an average of a couple of doses. So people don't necessarily sleep well when they come into the hospital. I don't necessarily think the best solution to that is to give them drugs. Any kind of sedative is going to be potentially causing delirium. Exceptions may potentially being melatonin and Ramelteon, which are work in completely different ways and may actually help in prevention of delirium. Ramelteon's been studied in that. It's studied for that in a number of different studies that have been recently published, and seems to potentially have some effectiveness in reducing the risk of delirium by normalizing circadian rhythms. But I'm getting a little off track there, so back to the diphenhydramine. As I said, about a quarter of them got diphenhydramine. They adjusted for baseline sleep difficulty and other characteristics. But the group that got diphenhydramine had increased risk of delirium symptoms, increased urinary catheter placement because the anticholinergic effects may have been causing urinary retention, and an increased length of stay. There were also it was a significant dose-response effect. So the more that diphenhydramine somebody got, the more delirium symptoms they had, the more likely they were to have major, basically, symptoms of cognitive impairment, as well as altered sleep-wake cycles. And of course, some of that could be that they're trying to target these altered sleep-wake cycles by giving sleep medications, but this was pretty clear in that the people who received diphenhydramine had worse outcomes. And this is consistent with a huge body of literature saying that drugs with strong anticholinergic properties are very risky for older patients and can cause cognitive deficits ranging from mild memory deficits to full-blown delirium. So some selected anticholinergics are listed here. I want to specifically highlight bladder antispasmodics because I think that they're overused in older patients, especially people with dementia who are at risk of the adverse cognitive effects from these drugs. They work generally through anticholinergic mechanisms, with the exception of one newer agent. Although some may be cross the blood-brain barrier more and have more cognitive effects, overall, the evidence that they're really necessary for older patients with incontinence issues is somewhat questionable in some cases. So I think the important things to think about are whether somebody is incontinent because they actually have bladder spasms, or if it's because their functional deficits are causing them to not be able to make it to the bathroom. So if they can't get up and get out of bed, then of course they're not going to be able to make it to the bathroom. If they have confusion, if they have dementia, they may have difficulty recognizing the cues that are telling them that they should be going to the restroom, or doing everything that they need to do to find the restroom and to toilet themselves. So some first-line recommendations would be to use scheduled or prompted voiding, where every 2 to 3 hours on an individualized basis, the person is either helped to use the restroom or prompted to go use the restroom. And that has actually been shown to be as effective as doing the same thing and adding the bladder antispasmodic oxybutynin for older nursing home residents with urinary incontinence. So that scheduled toileting, prompted voiding, I think is something we want to think about first. And then if you do end up using a bladder antispasmodic, trying to use one with less, that gets into the brain less, causes fewer problems. And monitoring its effectiveness and making sure that it's actually helping somebody. I've definitely talked with a patient's wife who I said, did this person's bladder antispasmodic help their incontinence? And she said, no, he never makes it to the bathroom. And so I'm asking, well, why is he taking this? You can see a number of other drugs there. Tricyclic antidepressants and antihistamines are particularly common anticholinergics. We also have some antipsychotics with anticholinergic properties. And you can find, I just want to note that this is on our Improving Antipsychotic Appropriateness in Dementia Patients website. We have a resource of drugs that may cause delirium or problem behaviors. This card on the right of the screen has anticholinergic drugs. So these are the common anticholinergics that are used. But you can see we've highlighted a number of the other medications that may be necessary but may also be things that you should evaluate as potential causes of confusion in somebody. So if you can just take a moment and think about what high-risk medications you often see and how often do you see them used. I'll stop for just a second. So now we'll move on to management. So as I mentioned before, the delirium can be caused by all kinds of different problems, medical problems, and so we want to search for and correct the underlying cause. Sometimes it takes a little while for a delirium to resolve, even after the underlying cause is resolved, and oftentimes it's multiple different things that we have to think about. We want to get rid of unnecessary medications and manage any withdrawal symptoms. And then the rest of the treatment is really about trying to treat their symptoms, manage their symptoms, keep them safe, and to control the environment to try to keep them oriented as well as we can. So some of the environmental interventions include support and orientation, making sure we communicate with them clearly and not use a lot of jargon. Having familiar people or objects around, cognitive stimulation may be helpful. Giving them other comfort. Radio or TV could be recommended, but people could also misinterpret that and actually be frightened by some of the things that they see. So that's sort of a plus minus depending on the patient and how they're reacting to that. We want to have good lighting during the day. Try to normalize the sleep-wake cycle as best as we can. Keep from waking people up at night if we don't have to. Try to make sure the surroundings are simplified so that they're not being misinterpreted. Make sure that people are otherwise comfortable, it's not too loud. We want to make sure that they have their glasses and hearing aids, as I mentioned, can participate in activity, and potentially if they can be mobilized safely, then that can be a good thing as well. Because early mobilization seems to help prevent this in hospitalization. So the overall goal, as I mentioned, is comfort and safety. If somebody is agitated or having psychotic symptoms, then we might consider antipsychotics. I think starting with very low doses is the right choice generally for older folks. If we're worried about extrapyramidal side effects, then we can use the newer atypical antipsychotics. But I think it is important to use antipsychotics short-term and not just to leave them on after somebody doesn't need them anymore, because there is evidence of increased risk of mortality and other problems with these drugs. They are not side effect-free medications, so we want to use them as needed to treat and manage the symptoms that people are experiencing, especially agitation and psychosis, but not overuse them. Benzodiazepines we want to stay away from, except in alcohol or sedative hypnotic withdrawal delirium, because they actually appear to make delirium worse. I've referred to them or heard them referred to as freeze-dried alcohol, and while that's not completely accurate, the effects can be really pretty similar to alcohol. And so if you think about giving alcohol to somebody who's already sedated and confused, that's not necessarily the best choice. Cholinesterase inhibitors have been evaluated, and I'll talk briefly about that. So there have been a number of placebo-controlled trials for antipsychotics in delirium. A few of them are highlighted here. There was one study that found that haloperidol, ziprasidone, and ziprasidone weren't any better than placebo, but that was more targeting abnormal level of consciousness in the ICU as opposed to targeting delirium specifically. There were a couple of studies with quetiapine that suggested that the group getting quetiapine did a little bit better than that getting placebo. And there have been a number of other trials comparing antipsychotics to each other. It becomes too many to really go through them each one at a time. Overall, there has been little to no difference in outcomes shown between the antipsychotics selected. You can see some of the more commonly used atypicals as well as haloperidol have been evaluated in these trials. But there are some things to note, and that is it really depends on the dose you're giving as to what differences you might observe in these drugs. So one study looking at fairly low doses of haloperidol found that they were pretty much equivalent to risperidone in symptom reduction and adverse drug reactions. So if we give that at a low dose, it seems to be fairly safe. Haloperidol is historically has been the antipsychotic that's been used most commonly for management of delirium, although I think it is perfectly reasonable to use an atypical antipsychotic as well. If higher doses of haloperidol are given, then we do see increased extrapyramidal side effects. So things like dystonia can be fairly common, where somebody has a muscle that locks up, and we have to give them anticholinergic drugs to allow that to resolve. It can actually be dangerous for people as well as very frightening. And so in this particular study, they showed increased extrapyramidal side effects versus olanzapine when haloperidol was given at much higher doses. So the conclusion of the authors of the Cochrane review on this, they were suggesting, well, maybe if you think you need a high dose, then to use atypicals. And I think that's a reasonable conclusion, although the other question would be, does a much higher dose actually help somebody or not? And so that, I think, remains somewhat of an open question. So the basic conclusions around antipsychotics, in my view, are that we don't necessarily need huge doses to get the benefits that we're going to get, and that it might not really matter which drug we choose. Olanzapine, quetiapine, and mid to low potency first-generation antipsychotics do have anticholinergic properties, and so my sort of personal bias is to shy away from those drugs for treatment of delirium for fear that they could worsen it. But the trials don't really show that, so that's just sort of, as I said, a bias that I have. You have to think about if somebody's got Parkinson's disease or if they're otherwise at high risk of extrapyramidal side effects, avoiding antipsychotics that are going to cause more of that, such as haloperidol. And thinking about in Parkinson's disease, I really wouldn't use a drug other than quetiapine. And the first thing I would do would be to reduce the dose of the drugs that are being used to manage their Parkinson's disease, because those can be causing delirium potentially. The haloperidol has been the standby for many years. So why aren't benzodiazepines recommended? Just briefly, there was a small trial quite a few years ago that showed that patients getting lorazepam who were delirious basically got worse. And even though this is a very small trial, most people agree that benzodiazepines are not the choice unless you're treating withdrawal from alcohol or from benzodiazepines or other sedatives. Cholinesterase inhibitors that are used for cognitive enhancement have been evaluated. The largest studies here have shown that rivastigmine increased death and worsened delirium in a large ICU study, and it was ineffective in another preventive trial in cardiac surgery. So I would say that right now the best advice is to shy away from these drugs. Physostigmine is an antidote for anticholinergic overdose that might be used in the ICU, but that's really a very limited setting in which that drug is going to be applied, and it's really only to overdose to anticholinergics and not tricyclic antidepressants because of the heart block that it can cause. We do have in the Improving Antipsychotic Appropriateness in Dementia Patients toolkit also a delirium assessment and management tool that you can review. This does have the CAM with some inserts from the CAM ICU included because those are on the minimum data set used in nursing homes. And so this is what people are typically using to evaluate these things. We just added a few cognitive questions that we thought could also be useful and gave some general guidance for assessment and management there on the left. So you can go review that information to find this if you'd like. For prevention, we want to avoid unnecessary medications and polypharmacy, use the lowest effective doses, evaluate every medication somebody might be getting because over-the-counter medications, those antihistamines and sleep medications really do seem to cause a lot of problems for people. Avoid sleep medications generally, again, melatonin and Ramelteon, potentially exceptions to that. And then we want to maintain orientation in the environment and taking somebody with cognitive impairment out of their environment into a new one can be very confusing and problematic, so avoid unnecessary hospitalizations and then try to manage medical conditions. There is a large and important trial done by Sharon and colleagues at that looked at delirium prevention in older medical inpatients. They found that addressing 6 risk factors reduced the incidence of delirium by about 5%. So to address cognitive impairment, they used an orientation protocol and cognitive stimulation. They tried to improve sleep on the unit. They tried to address immobility by using an early mobilization protocol and minimizing catheters and restraints. They tried to correct visual and hearing impairment, and they made sure they addressed dehydration and tried to identify that early. And so these are basic principles of good care that can really help improve outcomes for older patients. There are some studies now showing that in high-risk patients, antipsychotics at low doses may prevent delirium. I don't know anyone who's implemented this as a standard of care at this point in time, but they take these high-risk surgical patients and do show some improved outcomes. And so I really do think this is something worth considering, even though I don't know anyone doing it. The studies are growing to suggest this could be helpful to people with minimal adverse effects at the doses used. So back to BLANCHE. As you hopefully recall, she was an 82-year-old widowed female living at home. She had mild memory loss, but still manages pretty well at home with just minimal assistance. And then she was found before dawn wandering barefoot in her neighborhood in night clothes. And so to get a little more history on her, we find out her only sister died last week and the funeral was 3 days ago. She's been sad and tearful all weekend in response to the loss. She has had increasing confusion and struggling with memory and names. And then she wasn't sleeping well for the last 3 to 4 nights, and so that was putting her at risk due to her poor sleep and sleep deprivation. If we evaluate her medications, we can see she's getting a blood pressure medication. She's also getting a bladder antispasmodic, Detrol-LA, which can cause confusion for people. It's something that I've talked about and that I would recommend evaluating whether this is a good choice for her, especially given her cognitive impairment. She's getting paroxetine, Paxil-CR, which is the most anticholinergic of the SSRIs and is not necessarily the optimal choice for an older person with cognitive impairment. She's getting some other meds for arthritis, and then she, turns out, took Tylenol PM at the recommendation of her daughter at a pretty full dose, which probably pushed her over the edge into experiencing this delirium. So I appreciate your attention. I hope this has been helpful to you. Just to summarize, delirium is an acute and fluctuating type of cognitive impairment in attention and awareness. It is a sign of an underlying medical condition, and we need to evaluate and understand what medical condition is causing it in order to try to address it and resolve the delirium. Symptomatic drug treatments can help. We don't necessarily have to give everyone antipsychotics who has delirium, but if they're having agitation and psychosis, then it's a reasonable thing to do. Trying to manage the environment can help. in trying to keep them safe. And then, there are some preventive approaches that I think are worth considering, particularly those interventions studied in the large delirium prevention trial, which are really just about providing good care, but also potentially antipsychotics in some very high-risk populations undergoing surgery. So thanks again, and I hope this has been useful.